Hello, and thank you for joining us tonight for our free webinar, Tips and Tricks for Treating Knee Osteoarthritis, featuring Dr. Don Jung. My name is Jeff Bloom, Education Marketing Manager here at LhasaOMS. For over 40 years, LhasaOMS has been striving to promote the growth of the acupuncture industry by providing quality products, great prices, and the best customer service, as well as supporting the many schools and continuing education efforts available. With our free webinar series, we intend to provide free educational opportunities taught by some of our industry's most renowned practitioners and educators. I would like to take a moment to acclimate you to the webinar room. To the right of the video screen, you will see 3 tabs: Chat, Questions, and Polls. To chat with other attendees or to communicate any technical difficulties, please use the Chat tab. For questions of the guest speaker, please make sure to use the Question tab so we see them at the end of the lecture when we go through the questions and answers. Please note that each webinar is recorded, and immediately following the conclusion of the webinar, you will all receive an email with the link to view the video on demand and a copy of the slides. You may always visit our blog and use the free webinar tag to find all of our previously recorded events. From neuroscience to sports acupuncture to Chinese herbs, you'll find something interesting for every practitioner on the LhasaOMS blog. Now for our featured speaker. Dr. Jung received Western and TCM education in South Korea for 6 years, then completed an internship and residency at the National Medical Center in Seoul for an additional 4 years. In addition to the experience of an inpatient general hospital, he also owned and operated a private clinic specializing in pain management, administering over 100,000 acupuncture treatments to over 10,000 patients. Through experiences in both Western and Eastern medicine, his mission is to bridge the 2 fields of medicine together in hopes that patients benefit from the authentic integrative medicine. He has been teaching his systematic acupuncture for pain courses since 2015 to Korean medical doctors, and he's here today to share some of his advice with you. Please join me in welcoming Dr. Jung.
Hello, Jeff. Hello, everyone. Thanks for having me today. And I'm really thrilled to meet all of you guys coming from all over the North America and the other parts of the world, across the world. I'm so thrilled to share my experience and all the research about this issue with you guys. I hope this 1-hour webinar will enable you to see the knee pain patients more effectively and more based on the structured form of physical examination. So thanks again, Jeff, for introducing me, and I'm going to start with the first slide. If you have any technical issues, you can ask through the chat for Jeff, and Jeff will cover all the issues for you. Okay, I want to ask you a question about the knee pain. What if you saw a patient in the knee pain as an initial patient? What do you think of first? As our knowledge is based on the traditional Chinese medicine, I believe more than half or most of you may think that which meridian the pain falls into. Maybe that will be the initial thoughts, initial idea you think of when you see the patient. So think about that. If the patient has some pain about the anterior part or anterolateral part of the knee, you may think that the stomach meridian is the problem. So you may choose the stomach 34, 35, or 36 for the initial treatment. Or if the patient shows pain inside of the knee, so the medial part of the knee has some tenderness or many other symptoms, then you may think that spleen meridian will be the problem. So you may choose spleen 10 or 9 or sometimes 6, or many other points, including around the patella or the below the patella, or sometimes posterior knee will be the painful area. And then the ashy point will be a good candidate for the treatment. I believe this is the most people think about the knee pain. And it is backed by the study by Pong in 2012, which recapped all the acupoints used by the clinical trials, and that is the most frequently used 10 points about the knee pain. But I want to go a little deeper about the knee pain. This is the flow chart I use to diagnose the knee pain patient. And because I have only 1 hour today, I want to focus on the osteoarthritis only. That's cause the majority of the knee pain problem. But I want to introduce how I diagnose the patient with this flow chart. Just follow the flow chart with me. If the patient complains of knee discomfort, the first question I ask to the patient is it related to any kind of injury? If the patient says yes, then it should be dealt with in the category of knee injury or knee trauma, which falls into 4 categories like fracture, ACL injury, or MCL. ACL means anterior cruciate ligament, and MCL, medial collateral ligament, or the meniscal injury. They are the most common injuries that is happening in the sports in the sports injury or any kind of trauma. So I set a plan to figure out what's happening, in what structure is problem in the patient's knee, and many physical examinations such as Ottawa knee roll or Lachman test or valgus stress test or Thessaloniki test can be applied on each of the category respectively. But this is out of our scope for today. I want to focus on the knee OA. If the patient is not complaining, not reporting any kind of injury, then we have to do series of or structured physical examinations to the patient to confirm if the patient has osteoarthritis or not. The 3 tests we have to follow is let the patient do squats, and then we check the range of motion. And third is the Patella gliding test. So if you conduct the 3 tests, you should be able to figure out if the patient is related to the OA or not. And I'm going to tell you in detail with a real case and a lot of photos from the patient. It will be really helpful. And after diagnosing the knee OA with those 3 tests, you can decide if the patient's condition is good or fair or sometimes severe. It can be determined by the range of motion and exams for the fluid effusion. And I believe 1 hour is not just enough to cover all of that, but so I want to focus on the first 3 tests for today. And just for your information, the other categories I think about from the knee pain is postural twist, which is associated with weakness on some point of the hip muscles, or collapse of foot arch, or any kind of rotational factors happening in the hip, knee, or ankle. So it's about the biomechanical problem or ergonomical problem. And the 4th category is about the lumbar originated knee pain, which means the patient's knee is the main complaint of the patient, but many signs are indicating that the pain is coming from the lumbar area, and that will be covered by my back pain lecture. So maybe next time you can join in. So let's focus on the knee, and today's webinar are equipped with a case, a flow of the full case, and it is backed by multiple research about each section of the patient. So I want to go from this first slide. The first section is about the inspection. Every time you see the knee pain patient, you may see the patient's knee in your bare eyes. Even though the bare eyes is somewhat restricted about the value of the evaluation, but it reveals a lot of information, which is most of the time underestimated. But I want to focus on what we can do with our bare eyes. So first thing we can observe from the patient is the deformity. Deformity can be observed by this line. I wonder if you can see the joint line, including the stomach 35 or the Shi-Yan point. And this patient shows minor protrusion on the joint line, which is suggestive of deformity. And the second fact we can figure out from the patient is swelling. I wonder if you can see the photo, and I wonder if you can distinguish the differences between both sides. The spot we have to pay pay close attention is the point about around the medial patella. Let's compare the left and the right side. So for the right side, you may see that there is we can figure out the medial border of the patella clearly, which is shown like such as cliff or steep cliff towards the medial side. But for the left side, you may see that the cliff is not existing, or you may see the gentle curve that is falling from the patella to the medial knee. That means there's a minor swelling. So the pouch just next to the patella is somewhat swollen, so it makes the gentle curve. And the third thing we can notice is the redness. It's obviously, it can be obviously noticed by our eyes, but this patient do not have the redness. So we can figure out the deformity is existing on the joint line, and the swelling is mildly existing on the left side. That's what inspection can do. And I want to ask about the knee OA, about your thoughts. Basically, knee OA is the joint and cartilage or synovial membrane disease that affects more than 1 out of 4 people over age 55. And how do you diagnose it? Basically, it is diagnosed based on the clinical signs and the radiological evidences. So we have to do the history taking and physical examination, as well as the radiological findings should be referred all together. But in reality, we tend to overestimate the value of the radiology, and we tend to underestimate the value of history and physical examination. So today, I want to talk about the history and physical examination a little more about the details. So let's look into radiograph. Even though you are not, you have no background about the radiology, but you don't have to worry, I'm going to explain in detail. So this is the fibula, which means it's lateral side, and this is tibia, this is femur. The X-ray findings we see from this patient is as follows. The first one is joint space narrowing, which means the joint space between the femur and tibia on the lateral side, it looks like about twice as larger as the medial side. That means the medial joint space has been narrowed. And the second thing we can figure out is subchondral sclerosis, which means that joint cartilage cannot keep the bone safely, so the bone is going through the degenerative process. And the third thing we can find out is osteophyte formation, which means the irregular bone contour on the medial side or the lateral side of the bone. It is the spur, bony spur, and we call it medically as osteophyte. They are the typical signs of the degenerative changes, but interestingly, less than 50% of the patient who shows degenerations like this on their x-rays complains of knee pain. That means about half of the patient is non-symptomatic degeneration. So if we just only look into the x-ray, we can misdiagnose or overdiagnose the knee OA. So that's the reason why we have to focus on the clinical signs and medical history taking and physical examinations. And I believe acupuncturists are really good at it, already good at it. And I believe we can go further because we always palpate their knee to put our needles into the joint or into the muscle. So I believe our hand is so sensitive and so ready to touch every details. So I believe acupuncturist is the best occupation to do the palpation and physical examination. So please listen to the other rest of the slides. So then I want to ask you a question. If the radiology is not enough to see to diagnose the knee osteoarthritis, then which signs and symptoms we have to look into. And I could get a lot of information from this research by Sivera in 2004. This study was about the reliability of the knee exam in osteoarthritis, and look into the reliability. It's pretty amazing because the reliability is more than 95%. So thinking about the alignment by goniometer, its reliability is about 99%. And the bony swelling that can be palpated by our hand, it shows about 97% of reliability. The Crepitus, which can be manifested with our passive range of motion test, it shows about 96% of reliability. And the inflammation can be detected by effusion bulge sign, and muscle strength can be checked by quadriceps atrophy or quadriceps muscle strength test, which shows 97% of reliability. So it's really amazing. So that's why we have to do multiple physical examinations and put together all the information to make sure if the patient has some kind of osteoarthritis. So that's the way I allocate all the physical examinations about the knee, and I'm going to recap one more time. The first test we have to do for the knee pain is squat, and then passive range of motion for the flexion and extension. The patella gliding test can be done in each direction for up and down direction and the side to side. And we check the quadriceps femoris muscle strength to check if there is any atrophy or dysfunction of the muscle. And after that, we can do pinch roll if there are any texture changes over the skin just upon the quadriceps femoris. The last test I do is the exams for the fluid diffusion, which can be done in 3 phases. For the little and minimal fluid diffusion, I do swipe test, and for the intermediate one, I do cross fluctuate. Massive fluid diffusion, I do patella tap test. And I want to explain one more reason why I put quadriceps strength test not differently from the flow chart. As quadriceps strength can be weakened on multiple occasions, it's not indicative of knee OA necessarily. So in other words, it means that quadriceps femoris weakness can happen in multiple conditions, including knee osteoarthritis or lumbar originated knee pain, or sometimes just the pain itself inhibits the proper contraction of the quadriceps femoris. So it is just the non-specific sign of the knee pain. So I just want to check it after diagnosing the knee OA. And I believe that many of you have saw this image more than many times, because this is the most important or most widespread infographic about the knee pain or knee joint degeneration. So it is divided into 4 categories. The cartilage is intact or destructed less than 10% in the stage 1, and it gradually gets wear and tear, and in severe conditions about 60% of the cartilage is already gone. So they are the basic model for the osteoarthritis. But unfortunately, it makes the patient to understand the disease. But at the same time, it frustrates the patient. It makes the patient just forgive the treatment, and they just only expect when to go through the knee total replacement surgery. I believe it's not a good disclosure. Good discourse. So, for example, the main discourse out there in the orthopedic clinic or many clinics, they talk about the stories like it's something like wear and tear, or it's just like a torn tire in our car or something like a downhill trajectory, I believe that is really easy to explain to the patient, but all we have to do as an acupuncturist to engage them into the treatment and to let them exercise and keep moving and stay active to keep their muscle volume and to keep their proprioception. So I believe that's our duty and responsibility to keep the patient actively engaged to the knee treatment. And there's many researches that their pain coping attitude and their mood and their emotions affect to the knee pain itself. So as a practitioner, we have to be an artist to encourage the patient to actively engage to the patient and to see the minor changes and to do the proper physical examinations to figure out what is changing and what is improving. So I want to talk about that in detail. So I want to ask you a question about the joint degeneration and knee pain at this moment. So I came up with a poll. So if you can tap the chat questions and polls and people tab, you may see the polls. So how many of you think that the joint degeneration is the same thing as knee pain? Can you submit the vote? Can you vote? Okay, please, Jeff, let me know the result if you can see.
Well, it is overwhelming. The answer is no.
Oh, thank you.
You're welcome.
And I believe until now I'm conveying my lecture so well because many of you are thinking that the joint degeneration itself not necessarily associated with knee pain. So earlier slide, I explained that our duty, our responsibility is to make sure the patient to engage in actively and stay active and keep their muscle bulk about the knee. I'm so glad that many of you are so deeply engaged and paying attention to me. I'm so glad you are doing well. So let's talk about these examples. The patient A, B, C just presented their X-ray. So many of you will think that maybe the patient C present the severe pain, and the patient A may or may not have pain. We may say that, but that is not always true. So I want to explain why it is going like that. And this is a bit kind of technical question, but you can still answer by voting to the polls. Which is more relevant to knee pain? Tibio-femoral joint or patellofemoral joint? You can throw the poll.
All right, let's give them a couple more seconds because right now we are about 50-50.
Oh, really? It's so exciting.
It's actually really, I wish you could see the numbers going up and down because it's actually pretty fun. But right now we are at about 53% say patellofemoral. And then
47 goes to tibio-femoral.
Correct.
And I believe this kind of poll result give me a good point of view about what you are doing at this moment and what the other practitioners, like other disciplines like physical therapists or orthopedic surgeon, think about. The answer is the patellofemoral joint. It is there's not a constant flow of evidence, but one evidence supports the result about this about the patellofemoral joint. So let me explain that. Technically, there are three cartilage around the knee joint. The first one is tibia, and the second one is femur, and the third one is patella. And each of them are mingling just upon each other. And the study by Hunter, 2003, revealed that they did the research like this. They took the MRI for the postmenopausal woman, about 133 patients, And they compared their pain and functional score with the MRI findings, especially about the thickness of the thread bone. And the result was different from our common sense. The cartilage thickness between the femur and tibia is not relevant to the pain the patient reported. Rather, the thickness of the joint cartilage of the patella is significantly associated with the pain reported by the patient. This is quite amazing. But in the perspective of biomechanics and the ergonomics, it's not that surprising. And I wanna explain why it is. So yeah, I will explain that in the next slide. So as a recap for until these slides, I can recap four cofactors that is affecting the knee pain based on another research. And the four factors are like this: muscle weakness, or patellofemoral joint cartilage, or pain coping, or synovial fluid, the amount of synovial fluid. It's quite amazing because the joint line narrowing, or tibiofemoral joint line narrowing, is not significantly associated with the knee pain. An interesting thing is the pain coping, which means if the patient is somewhat in anxiety or depression, the patient is more likely to experience pain. Or if the patient is pessimistic rather than optimistic, the patient is likely to have more pain. So I'm going to deal with that later in next chances. And today I want to focus on the muscle weakness and the patellofemoral joint cartilage. The muscle weakness significantly affects the pain. In terms of knee joint itself is stabilized by the quadriceps femoris muscle. So it is the most important muscle we have to treat. And in terms of patellofemoral joint cartilage, the mechanism that the cartilage wear and tear is determined by the direction of the forces around the patella. And let me talk about that in the next slide. This is the conceptual diagram about the forces around the patella. All the arrows in blue color means that the arrows is pulling the patella outward laterally, and all the green arrows, they pull the patella inward medially. And in the normal circumstances, they are in good balance. So the medial force and the lateral force, they are in balance. But think about some pathology conditions, such as if vastus medialis on top of the patella, they are inhibited by any reason, then the patella will go outward and making more friction between patella and femur and making wear and tear to the cartilage. And another example is the weakness on the vastus lateralis. So if the vastus lateralis is not working properly, then the patella can collide medially and make unnecessary friction on top of the femur. So that's why we have to consider biomechanics and the weakness of the vastus lateralis and vastus medialis from the patient. And let me show you how I treated the osteoarthritis patient. What do you think of when you see this photo? This patient was 71-year-old female presenting knee pain. But other than knee pain, this patient had Herbal nodes on her distal interphalangeal joint, and it was showing a little bit of redness, you may have noticed. And for the left photo, her range of motion for trunk flexion is much better than the average. many of you will think that, oh yeah, this person is so flexible. But actually, it can be evidence of flexibility, but otherwise, it can be evidence of degeneration, because the disc and the vertebra, it contains a lot of water or proteins in it. But once they go through the degenerative processes, its height is reduced. So it means their overall height is reducing, and they can go further because they have more wiggle room to go forward. So if the patient can reach out further than the average, it sometimes means that the patient is going through the degenerative changes, maybe including spinal stenosis or osteoporosis, many other kinds of degenerative changes. And it is backed by a research by Thomas in 2013. The researchers compared the knee pain patients and other patients, and they compared what's happening. And the yellow bar means the knee pain patients, and they complains of knee osteoarthritis, and at the same time, they complain other musculoskeletal diseases and overweight and rheumatologic arthritis. So based on this research, we can think that knee pain patient complains more than one symptom, including knee pain. So we have to listen to their other symptoms at the same time, and I believe we can go further with them, including those symptoms. So the doctors, especially the orthopedic surgeons, they are really good at surgery, and I believe they are so crucial to keep our human race's health. But sometimes we need to see not only the knee joint, but also we have to see the entire human body and the human as a whole. So that's the reason why we have to see other joints and other complaints of the patient. And just I mentioned earlier, the first physical examination that I do is let the patient do the squat. Can you squat? Then the patient answered that, oh no, I can't. So I let the patient hold the table and go as far as you can. And that's the maximum the patient could do. So that means the patient cannot go further. And so the range of motion is limited. And it may be due to the muscle strength, because the quadriceps femoris cannot hold the knee tightly. And another possibility for this limitation is the coordination. If the patient has poor range of motion for the hip or ankle, it also can restrict the full squat range of motion. So after recognizing the restriction for the squat, we can do detailed test about each of the conditions. And the next step I do was the passive range of motion test. Passive range of motion test reveals a lot of information about the joint itself. Imagine that if the joint is swollen, the joint fluid restricts the full range of motion, so we cannot go further into the limit of the motion. So we may feel restricted feeling when we go further, when there's joint swelling or some kind of joint destruction, such as bony spur or joint line narrowing, which was revealed by the radiology. And we can see that by passive range of motion test. Look into this patient and let's compare the left and the right side. I can measure the distance between hip and heel. For the left side, you may see that there's only 1 fist of distance between the heel and hip. But for the right side, once I put my fist on top of the patient's butt, there's more than 1.5 or 1 2/3 of my fist between the heel and the butt. That means the flexion is limited. And sometimes if the patient cannot extend the knee fully, it means there is a flexion contracture. So Technically, the knee is floating on top of the bed in that case. And as for your information, I brought her x-ray and it showed joint space narrowing undoubtedly, and osteophyte formation and deformity of bony contour. So she was diagnosed as knee osteoarthritis, but without radiological findings, I could rule out that this patient has osteoarthritis. And let's look into the chart. This chart, this patient was 71-year-old female complaining of knee pain, heaviness, and pulling sensation. Especially, she experienced difficulties in walking down on a slope. And she had insidious onset, which is really important because if the patient is showing, is reporting injury, it is less likely to be osteoarthritis. So the insidious gradual onset is the one of the factors that is associated with knee OA. The physical examinations that I've done was written like this. Full squat was impossible, and the patient could go up to the horizontal level. The passive range of motion was restricted on the right side, especially about 1.5 fists. For the patella gliding test, the right side, or the right knee was minimally having the flexion contracture. So the quadriceps muscle and the patella ligament was somewhat elongated, so the patella movement was unable to be detected. So there was no movement on the right side. But for the left side, it showed mild side glide, showing a little bit of wiggle room. For the fourth test, I checked the quadriceps femoris muscle, which showed weakness on the right side. And for the fluid diffusion test, mild swelling was existing on the left side, on the right side at the same time. So I ruled out the patient as osteoarthritis of the knee, and the impression by the radiology was osteophytes formation and signs of degeneration, confirming my diagnosis. And let's focus on the plan. And I believe more than 90 or 99% of you may focus on the plan, treatment plan. So what have you done for the patient? Now I want to answer that question. Acupuncture with electrical stimulation was done for the quadriceps femoris muscle, especially on the right, for the vastus lateralis at the same time. And exercise was prescribed for the patient to do the half squat 100 times a day. Every time I recommend or prescribe the exercise, I do not expect the patient will follow that. Maybe less than 10% of patients do that. But amazingly, this patient done 300 times of squat, thankfully. So that was the reason why she showed such a quick response about the treatment. And let's look into this photo. This photo was about the treatment for the same patient. You may see the cupping mark around the knee joint, especially about the vastus lateralis, medialis, and rectus femoris. And you may extend more cupping on top of that across the thigh. And let's look into the right side first. The yellow line is connected to the rectus femoris muscle. And the second line, which is white, was connected to the vastus lateralis on the right side. That's because she showed significant weakness on the lateral side in particular. And that's the reason why I did vastus lateralis. And generally, I do stomach 36 to utilize more stimulation around the knee. So that was my initial treatment, and I repeated that more than 5 sessions. And I want to give another an additional example about the knee pain. Even though it was not exactly the knee osteoarthritis, it was a kind of sports injury, but the treatment protocol was a little bit same. So the key message I want to give with these two cases is that no two patients are treated alike, because they have their own mechanism and they have their own painful area. So I have to look into individually what is the problem in this patient, and I have to build up the story, their own story. So let me show you a video about this patient. You may see the video. And this patient was stimulated by the electrical stimulation.
Were connected to the rectus femoris and the only.
You may have seen the twitch of the muscle with the electrical stimulation. The intensity I want to go with the electrical stimulation is the level the patient can tolerate. So I go as much as possible until the patient can tolerate. It may go 4 to 5 in many cases with my electrical stimulation machine, Ito ES130. And let me show you one more time. So you may see the twitching on the vastus medialis, which is the teardrop muscle, showing the morphology of like a teardrop, and it's contracting rhythmically. Jeff, sorry about that. Can you show up the slides? Oh, thank you. So this was the patient showing weakness on the medial side of the quadriceps. So I targeted the vastus medialis obliquus. And I want to, this point of view, such as the weakness on the vastus medialis obliquus, it is backed by a study by Fink in 2007. And sorry about that. Fink looked into the morphology of the muscle of the knee OA patient and realized that the patient showed type 2 muscle atrophy. There are 2 types of muscle fibers, one for type 1 and one for type 2. And there is intermediate fibers, but I want to just compare those 2 types. The type 1 fibers are just like marathoners. They go long way, even though they can exert a small amount of forces. But type 2 muscle fibers, they are splinters. So they run so fast and they can go a short distance and they can exert large forces. But mainly type 2 muscles go through atrophy. It can be affected by the age because about 7% of the muscle is wasted as we go. 7% of the whole muscle is decreased by decade. So it can be coming from the age-related factor, or anyway, it shows type 2 muscle atrophy. And another mechanism works beneath underlying for the weak vastus medialis obliquus is the pain-associated disuse. That's the reason why I mentioned engagement. Once the patient experiences pain around the knee, they feel frustrated and they are not willing to walk or run. And that makes the muscle atrophy, and it enhances it aggravates the pain. That works like a vicious cycle. We have to cut some of it or all of it. So we have to encourage the people to move more, and the treatment by electrical stimulation, as you watched earlier, the electrical stimulation for the specific muscle is somewhat effective. And the third mechanism underlying is neurogenic muscle atrophy, which is related to the nerve root, a spinal nerve root, or inhibition between those structures. I'm going to mention that later on. So I want to show you how did the patient change it and how was the improvement like. The patient's initial diagnosis was done in April 25th in 2019. And after 2 weeks of treatment, about 4 to 5 sessions, you can see the improvement of the range. Passively, I could press about 1.5 fists earlier, but Afterwards, I could go about 1 inch more. You may say that 1 inch is not a big thing, but in terms of passive range of motion, 1 inch of improvement is a lot. And in terms of pain scale, the patient reported more than 3 steps of reduction in terms of intensity, which means we may indicate 0 as no pain and 10 as most extreme pain. The patient described the initial pain as 7, but after 1 inch of improvement in terms of range of motion, the patient reported only 4 out of 10. That is a lot in 2 weeks for this 71-year-old female patient with knee OA. So I want to stress that the change, if you are not expecting the improvement out of patient, the patient may not experience it because you are not expecting that. But if you expect the improvement, the patient will do. So please don't lose the hope, and we have to keep going. That's our work. And there's another study by the Acupuncture for the Knee OA, which is really recently reported by two in 2020, and it compared the massive treatment more than 3 times a week for more than 4 weeks. The patient was treated in 3 arms. The first one was electroacupuncture, the second one was manual acupuncture, and the third one was sham acupuncture. The result was like this. The outcome was measured in terms of response rate. The blue one, the electroacupuncture group, showed more than 60% of response rate over over 8 weeks of treatment. And the green one, the manual acupuncture group, showed just below the 60% of response rate compared to the sham acupuncture showing around 40% of response rate. And amazingly, the effect was lasting over 26 weeks. That is 6 months. So I believe some may say the effect of acupuncture is somewhat temporarily, so it goes away in a few days. But if it is done in an intensive way, 2 or 3 times a week, more than 4 weeks in a row, it can give prolonged effect about the knee pain. It is proven by this research. So I hope you to see the original article if you want, and you can Google that by Googling these facts. So as a recap, I want to summarize the breakthroughs we have been looking. In terms of diagnosis of knee OA, I want to stress that knee OA should be diagnosed based on the clinical signs and the radiology, but we have to focus on the history and physical examination because it's usually underestimated. And the second breakthrough was that the knee joint degeneration is not necessarily associated with knee pain. And the third fact I want to stress is that not only tibia femoral joint, but also patella femoral joint is important, or somewhat patella femoral joint is more important than the tibia femoral joint. And we can control that by acupuncture. And this was the physical examinations that I'm doing. And I want to stress that the first thing you have to ask for the patient is that if it is associated with injury. If not, you can go through the step by step. The first one is let the patient do the squat, and the second one is passive range of motion. Flexion and extension can be checked, and I showed the flexion, measuring the distance between the heel and the butt. The third one was patella gliding. You can do it up and down and side to side. And the fourth one was quadriceps muscle test, and the patient may show lateral side or medial side of weakness, which can be associated with vastus medialis and lateralis. And the last test, we can check the progress of the patient is the exam for the fluid diffusion. And I want to introduce that in the next course, which will be rolled out in May or June. So I'm currently recording it, and editing should be done over the next few months. So over the next couple of months. So I'm gonna try my best to roll out that as fast as possible. So please pay attention to further notice. So as a bottom line, acupuncture for knee OA can be subdivided into multifaceted approach, and I want to explain each facet. The muscle weakness can be treated by stimulating the quadriceps femoris immensely by giving decent amount of electrical stimulation by our electrical stimulation machines. And the patella femoral joint cartilage can be protected by rebalancing between the vastus lateralis and the vastus medialis obliquus, which can be detected by muscle strength test or pinchy roll over the muscle. And to increase the pain coping capacity of the patient, we can let the patient think positively and have more hope about the improvement, and we can needle stomach 36 or GV20 or large intestine 4 or liver 3, which can be enhancing the overall effect of the analgesic effect of acupuncture. Additionally, if the patient shows synovial fluid effusion, we can needle Shiyan or stomach 35, as we have done before, to put the needles into the joint capsule or just upon the joint capsule and do the stimulation by the electrical current. That will be great combination of the patient. And one more principle I want to stress is that no two patients are treated alike. They have their own stories, and I believe our role is to figure out what is happening within this patient and set up the right plan for the patient and do the accurate and appropriate treatment for the patient. Thank you for listening, and this was my 1-hour webinar for knee pain, especially about the osteoarthritis. Thank you for listening. Bye-bye.
Thank you very much. Actually, we do have a fair amount of questions here, so if you are available, we can go through and answer some of them.
Yes, I'm good. Wow,
all right.
A lot.
All right, so first question is, what are your thoughts about treating a complete meniscus tear and the doctor recommends surgery?
Yes, let's talk about the meniscus. It's really widespread. And what about, yes, the doctor says complete meniscus tear. And I believe, and I have to mention two facts. The first one is that there are many asymptomatic meniscal tear. That's true, and it is proven by a lot of research about the meniscus. But one thing, if the patient is experiencing severe joint swelling and locking or giving way, then we should think about surgery. And there's two main symptoms that we have to consider surgery. The first one is swelling, which is not controlled by conservative treatment. And the second one is locking, which means the fragment of the meniscus is somewhat stuck in somewhere else in the joint, so it's locked. So you cannot flex or extend the knee at some times. That means the meniscal tear, the consequences of the meniscal tear is so severe. So in that case, we have to think about the surgery. But I want to tell you the fact that is backed by multiple research. In terms of meniscal tear, because it's so widespread, something like, I want to compare that. You may heard that there's many asymptomatic disc protrusion in our back, which is detected by MRI, and there's many asymptomatic rotator cuff tear that is detected by MRI or sonograph, or there's many asymptomatic meniscal tear in our knee. So there's more than many research about that. And interestingly, I want to introduce one interesting study. In Finland, I remember that it was Finland, they divided 150 or more patients into two groups. One group went through surgery about removing the destroyed part of the meniscus. And the second group went through sham surgery, which means they just went into the joint, looked what's going on, and they detected meniscal tear, and they just came out. The result was compared in 3 months later, 6 months later, and 12 months later. For the 3 months later, the surgery group, the real surgery group, was much better. But as time goes by, 12 months later, both groups showed same pain and same function, which is really interesting. So for the minimal or moderate form of meniscal tear, we can expect conservative treatment, including acupuncture, will work. But for the severe symptoms, including these uncontrolled swelling and the locking, yeah, it is indicative of surgery.
All right, next question. Do you have any tips for treating knee pain due to a bad contusion of the tibia?
It was a good question. Bad contusion of tibia. I wonder what caused that contusion. It may be originated from motor vehicle injury, because a lot of dashboard injury is related to the tibia. Or it can be any kind of sports injury. I'm not sure. But as a conclusion, in brief, I would say contusion itself can be treated by needling superficially around that area, putting multiple needles and connecting electrical stimulation around that. But I'm not sure what you mean by bad contusion. So if you have any photos, it will be helpful to see. But if the bad contusion is not fracture, I would say it is good candidate for the acupuncture.
All right. Next question is, what are your thoughts about needling deep into the patella to regenerate cartilage?
Then we have to think about what is the cartilage and what does acupuncture do for the specific tissue we are in. In terms of components, the tendon or ligament consists of collagen fibers. Collagen fibers are something from proteins, and it can be regenerated by proper stimulation. And even though it's slower than the muscle tissue, which is really rich in blood vessels and nerves, but the tendon itself, it has no blood vessels, so it will take 3 times or 4 times more to get better than the muscle tissues. But in terms of hyaline cartilage, the component is different than the hyaline cartilage is different than the collagen fibers. So I would not recommend to needle the hyaline cartilage with the acupuncture, because the possibility for the regeneration is not that high. So it is less likely to regenerate after the micro trauma we make with our needle itself. So I mainly do acupuncture massively for the muscle, because it heals much faster than the other tissues. But for the tendon, I believe I should go a little bit closely, or a little bit just next to the tendon, not into the tendon, because the peritendon, which is surrounding the tendon, can be beneficial about the microtrauma, but the tendon itself is usually painful, and it goes a little slower than the muscle. But for the hyaline cartilage, I definitely do not recommend to needle that.
And then this question actually piggybacks off of that question. What are your thoughts about an acupuncture approach to treating the knee pain when circulation has also been compromised? For example, a vascular necrosis.
That is great question. And many things happens, necrosis is happening around the femoral head, femoral neck, femur. And I have to confess that I have more than a couple of cases about the AVN, avascular necrosis. And the result was not that satisfactory because they just go their progress. They just progress. But at least I can control the pain a bit. In terms of pain intensity, I can make the pain intensity 7 to 5, but it goes about 7 to 5 and 6, and that is the main course. It doesn't go down below 4. So in terms of avascular necrosis, unfortunately, I see the limitation of acupuncture for that issue.
Alrighty, and moving along, are you okay if we take a few more questions?
Yes, I'm so good.
All right, perfect. Next question is how do you treat crepitus?
Crepitus. In terms of crepitus, if it is associated with pain or range of motion, limit of motion or restriction, we should pay attention to that. But in terms of crepitus itself, without pain, without any range of limit of motion, then it is unresponsive. So I would say if it is associated with pain and dysfunction and limit of motion, I do recommend to treat. The most likely area that is associated with crepitus is TMJ, temporal mandibular joint, or your wrist, or your shoulder, or your neck. But if you focus on the crepitus itself, it is really hard to remove the crepitus. To remove the crepitus, we need more, in terms of principle, we need more stabilization. We need more smooth tendon or smooth ligament. We need more bursa that is working. And we need more space between all the structures. So to establish all the requirements that I mentioned earlier, it's not that easy. That means that if you are experiencing crepitus in your 40s, you have to go back to your 20s. So it's not that easy. So we have to embrace the crepitus somewhat, something like gray hair or something like wrinkles on your face. And crepitus is just the consequences of minor degenerative changes in the tissues like joint capsule or bursa, tendon, ligaments. All the combination of minor destructions or minor degenerations, they manifest as crepitus. Okay.
All right, and then are there any conditions that you avoid electrical stimulation?
Yes, I do sometimes. It was a good question. For the patient with pacemaker, I do avoid. And for the patient who is really afraid of electrical stimulation, I do not do that. And for the patient who has some issues about the electrical stimulations, for example, if the patient's family has some issues about the epilepsy, or the patient himself or herself has kind of epilepsy, I do not recommend to do the electrical stimulation.
Alrighty, next question. Please comment on patients that have significant genu valgus and treatments that can address knee pain in addition to this biomechanical change.
Wow, that is a huge question, even though it's good. But I believe, I need more than 20 minutes to explain that in full, but in brief, genu valgus and genu varus, it is massively related to the knee mechanism. So we have to take that into consideration when we treat the patient. And that's the reason why I told you that no two patients are treated alike. But in terms of, then let's talk about briefly about the genu varus, because it is significantly related to the knee OA. Many patients over age 70 or 80s, they have more space between their knee than their ankle. That means they have bowed leg, which is expressed as genu varus in the medical term. In that case, we have to look into the medical conditions in terms of layer. First of all, the patient may have joint space narrowing, we mentioned earlier, or the wear and tear of the cartilage, or the reduction of the height, or in some patients, they can have discoid meniscus, which means the lateral meniscus is much taller than the medial side. It can happen to many patients. So discoid meniscus or knee OA can be a factor for the bowed leg. And the rotational factors or postural factors, including hyperpronation of the foot, or internal rotation of the tibia, or weakness of the hip muscles, hip stabilizers, or antiversion or antiversion or retroversion of the femur, or pelvic distortion. Many factors are included in the set, included and working as a team to make the genu valgus or varus. So that's what I can say for briefly, and I wish I can have more time to talk about the postural or biomechanical aspect of the genu varus, and I believe it will be launched in March or June. Please keep in mind, please pay attention to the further notice. Thank you.
All righty, and we still have a few more questions here.
Yes.
How long do you typically leave the e-stim on? Is it 10 minutes or longer? And does it depend on the patient?
Based on many research, 20 minutes are recommended. But if you are in a hurry, you have to treat the patient in 30 minutes, then you can reduce it into 15 minutes. But I do recommend more than 10 minutes should be done for the decent amount of stimulation.
All righty. And then how do you treat rheumatoid arthritis in the knee? And can we use a similar method?
In brief, the answer is yes. But it should go bilaterally if the patient is complaining of both-sided bilateral knee pain. And one thing we have to keep in mind is that the rheumatoid arthritis is not only the joint disease, it is kind of immune disease. So we have to think about utilizing points associated with the meridians in about the spleen or the kidney or liver meridian, or we can use appropriate herbal formula or herbal medications to promote their immune systems. Or basically for the rheumatoid arthritis, dietary advice, it is so crucial to maintain the inflammation level, which can overly activate it for some patients.
Well, piggybacking on dietary recommendations, we also have a question. Do you have any herbal or dietary recommendations for knee osteoarthritis?
It is such a huge question. But for me, as I prescribe more than hundreds of herbal formulas in Korea, I have much experience about 대방풍탕 in Korea, but I'm not sure how to translate it into English. I'm gonna post that. I'm gonna keep you. So please email me about that. I can give you more information about my herbal formula information. And
Okay.
and for now, I'm not familiar with the herbal products in US. So now I'm getting to know about that. So I'm gonna let you know once I get familiar with all the products. There's more than thousands of products. Okay.
All right,
And my email is acupuncturesystem@gmail.com. Okay.
Perfect. And I just put it into the chat. So if anybody would like to send Dr. Jung an email, just take a look in the chat right there. Next question. What do you recommend for a complex medial meniscus tear that occurred in May of last year, where I can do everything on it except for run on it or kick while practicing Hapkido without irritating or inflaming it?
Wow. Yeah, it was a great question. And I can see more than tens of patients about that issue. Complex medial meniscus tear. Because most of the meniscus tear is happening in the medial side. And many cases are associated with complex tears. But in fact, I do recommend you to focus on the symptom. Can I read that question once again? Yes, the complex medial meniscus tear that occurred in May of last year, where I can everything on it except run on it or kick while practicing Hapkido without irritating and inflaming it. I'm not sure what kind of movement you do when you do Hapkido. But for the meniscus is really vulnerable to the rotational forces. So if you are doing some kicking, extending the knee fully and rotating the lower extremity, I believe it will impose more stress to the meniscus, and the complex tear may progress. They may progress to the further tear. So I definitely, as a principle, I recommend you to avoid rotational issues. But I'm not a fan of Hapkido. I don't know what they do. So in terms of principle, the rotational forces around the knee is really harmful to the meniscal tear.
Alrighty, and then do you have any information about treating people with metal implants with eStim?
Metal implants about what? Can you tell me?
With electrotherapy, like would you stay away from treating a patient that has metal implants?
Oh yes, okay, that was a good question. Metal implants can be treated. For example, I want to give you an example with my real patient. The patient had fracture on his tibia and fibula. So the patient had pins and metal implants in it. But I could stimulate the peroneus superficially and just next to it. Not into the implant, but next to the muscle itself. And I could see that the muscle was contracting properly after the treatment. So if you avoid the focal area of metal implant, you can still go. And if the patient is hypersensitive about that area and afraid of the electrical stimulation, in that case, you should avoid that. It depends on the patient.
All right, let's do two more questions.
That's good.
So for the first of the last two, what hertz setting for frequency do you typically use for eStim?
That was a great question, because I get this question more than tens of times when I do webinar or in-person lecture or for the spectation for my clinic. Many practitioners ask about this because there is no solid evidence about that. But the evidence that I collected from the earlier research reveals that for the chronic pain, lower frequencies between 1 to 10 or 16 hertz are better than controlling the chronic pain than the higher frequencies such as more than 100. And for the immediate effect of the electrical stimulation, higher frequencies over 100 is better, but it's not lasting longer than the lower frequencies. But so I do recommend to use the lower frequencies for the chronic pain over 6 weeks of pain, which is the majority of our acupuncture clinic. And the interesting thing is that the electrical stimulation has somewhat cumulative effect. That means 3 times a week, twice a week treatment, which was administered more than 4 weeks, has more effect than the occasional treatment, like once a week or having intervals more than 2 weeks. So I recommend you to do 8 to 10 sessions for the electrical stimulations in short time, in 3 weeks or 4 weeks, and you may see a remarkable change due to the treatment. And there is a research comparing the electrical stimulation to the muscle strength exercise, and it reveals that there are three common facts about the electrical stimulation and the exercise. The first thing is that both of them release endorphin, beta endorphin, and second, they have cumulative effect. So we have to exercise regularly and constantly. The third one is it can enhance the strength, and it can modulate our emotions as well. So I believe that's the benefit of electrical stimulation in brief.
Perfect. And then is there a frequency setting on the device that you typically stick with, or do you change that based on the patient?
When I was in Korea, I used mixed frequency from 1 to 16. The machine changes the frequency by their programmed setting. But for here, I bought Ito ES130, which gives only a constant frequency only. So I mix it. So for example, I do twice 2 hertz for 5 minutes, and then I change it 8 hertz for 5 minutes, and the last 5 minutes goes about 1 to 2 hertz. So I mix the frequency, because if a single frequency is done more than 10 minutes, the patient really adapts that frequency so quickly. So in the research that I've seen, it revealed that 8 minutes was the threshold. So if the same frequency goes into your body more than 8 minutes, it's no longer a stimulation. So you should tweak the frequency, or at least you should control the intensity. If you control the intensity a little bit more, about half notch or 1 notch, it can be another stimulation because the intensity changes. But if not, you can change your frequency.
Perfect. And actually, we did have somebody who clarified what the formula that you were talking about was. So it is Da Fang Feng Tan.
Yeah, right. That's right. Thank you. Thank you.
Yes, we appreciate you very much. And then for the very last question, are you also successful in treating osteoarthritis in the CMC, the carpo-metacarpal joint?
Wow, that's really tough. Yes. Then I have to confess with my case report that I've done for the CMC joint, and as well as the DIP and PIP joint. The most remarkable, the case I recall at this moment is the DIP joint case, which is really similar to the CMC joint. Let me tell you the case. The patient was about late 60s of her life, and she had long history of more than 5 years of degeneration on her finger on the DIP joint. And she had nodes, which was really remarkable on both sides. So I treated with 2 needles on each side with thicker needle. But as you know, our extremities are highly sensitive for the stimulation, because the receptors for these receptors detecting the touch sensation or pain, it is really dense compared to our trunk. So the needling on this spot was really painful for the patient. So after 5 to 6 sessions of treatment over 2 or 3 weeks, the patient said that No, that's enough. That's enough. So I believe if the patient is willing to get the treatment for the long run, it will be good. And I can see some patients got improved in the early phase. If the history was less than a couple of months, then it may show redness or minor nodes on top of the joint. It can be reduced by the needling or bloodletting or moxa on top of the node. It really works. So for the early stage, but for the late stage, like over 5 years, I've never seen that was responsive than the acute phase. Thanks for the good question.
Yes, well, thank you for all of the amazing answers. Thank you for all of the amazing information. I've been looking at the chats and the questions the entire time, and it is filled with a ton of appreciation for you. So really, thank you. I do want everybody to know that Dr. Jung just released a class, which is now available for sale at LhasaOMS, and it is actually on back pain. So it's called Systemic Acupuncture for Back Pain. If you check your email in about 5 minutes, you will have a promo code that's going to give you a discount off that class, as well as pretty much all products at LhasaOMS with just a few exclusions. So check your email. Don't forget about that. And then on March 17th, we'll be hosting Marie-France Colin for a webinar on practical auriculotherapy. So don't miss that. And I hope everybody has a wonderful night. And thank you again, Dr. Jung. It was wonderful.
Thank you so much, Jeff. Bye-bye. Bye-bye.
Good night, everybody.
Mm-hmm.